Working with clients suffering from schizophrenia present a unique set of challenges. Schizophrenia is often a debilitating mental illness. It is most well known for the symptom of psychosis that can commonly lead to violent behaviors from the client. Other symptoms include unusual behaviors, poor hygiene, bizarre or unusual dress or appearance, unusual speech, unusual motor behavior, and emotional reactions that do not appear to fit the circumstance. For example, a client may witness something highly traumatic to most people but not have any emotional reaction to it. Or a client may seem to overreact to something that does not appear to be a big deal to anyone around. The average age of onset occurs on or after puberty, approximately age 18 to 25 for males and 25 to 45 for females. However, there are documented cases of childhood schizophrenia. In the case of Janie Schofield, she showed symptoms in infancy. Two of the marked symptoms present with Janie were that she did not sleep much. At a time when infants usually sleep the majority of a 24-hour period, Janie slept maybe 1 to 3 hours at best. Also, Janie began showing obvious signs of hallucinations as early as 3 months old. Her parents have video of her clearly following something that she was seeing that was not there. She followed the invisible object with her eyes and head around the ceiling. As Janie grew, her symptoms became highly acute. Typically, the younger a client is when they start exhibiting symptoms, the more severe the prognosis, and Janie is an example of this. There are no indications that cultural or socioeconomic variables play a role in this illness. Religion can play a negative or a positive role when considering a client with schizophrenia. In some instances, religion can give inspiration or hope to a client. Religion can also adversely affect some clients and contribute to negative spiritual hallucinations of demons, devils, and the like. Studies have shown that Christian patients have the highest prevalence of hallucinations related to shame and guilt when compared to Muslim and Buddhist patients. One ethical issue regarding clients with schizophrenia concerns the client's right to self-determination. When clients are experiencing their episodes of delusions or hallucinations, they often will not realize that the things that they are hearing, seeing, or experiencing are not actually happening, as these things will feel real to them. Therefore, the client may not be open or receptive to receiving treatment. Because of this, many clients with schizophrenia go untreated, and this is their right. It is only if their behavior is a harm to themselves and or others that intervention can be imposed upon them. Even when this does become necessary, it is always important to consider their right to self-determination as much as possible. Since schizophrenia has a high correlation to be passed along genetically, assessing for family history of the illness will be a primary component for diagnosis. Other things to look for in the assessment phase are if the client has become detached or withdrawn from family, friends, and loved ones. Has the client had trouble with work, school, or normal daily routines? Has family and friends of the client noticed strange or unusual thoughts, actions, or behaviors from the client? Has client lost interest in hygiene? Has client begun engaging in risky behaviors? Has client had major changes in sleep-wake patterns? Most importantly, the client must be experiencing delusions, hallucinations, or disorganized speech for a significant amount of time during a 1-month period.